I have chosen this topic because sometimes it is tricky to identify and characterize splenic lesions. So we'll start our lecture. So first of all, we will discuss about benign focal lesions of spleen. And this is a interactive session. So first I will show you the slide and our senior PGs will interpret the slide and then we will move forward to the slide which will explain the preceding image. So let's start. Okay. Ji, Dr. Zara, kindly explain this, describe this lesion. Mm, okay. Mm, mhm. What do you think? Is it a benign lesion or malignant lesion? Okay. Okay. What do you think what it is? Very common benign lesion of spleen. Okay. So, okay, good. So, let's first, I will brief you about the images of this slide. So this is the T1, this is T2, and this is a lesion at the periphery of the spleen, which is hyperintense on T2, T1, and hyperintense on T2. Okay. So on post-contrast image, it is not showing enhancement. Okay. So if it would have been a hemangioma, it would have shown peripheral puddling, enhancement. So this is a benign lesion, splenic cyst. Okay. So splenic cysts are most frequent benign focal lesions of spleen. On ultrasound, they are hyperchoic. On CT, they show water intensity and they are well defined. They do not show post-contrast enhancement. On MRI, we all know that on T1 images, it appears hypointense, and on T2 weighted image, it appears hyperintense. And you know, pseudocysts sometimes can also occur or are present in spleen. They can also be present even in thorax pseudocysts. I have seen few cases that pseudocysts are located at very odd locations. But characteristics of pseudocyst would include slight shading on T1 weighted image because of and T2 weighted image because of its proteinaceous content, and it may be loculated internal septa or etc. So let us move to the second slide. Okay, so Dr. Muhammad, please explain this slide. Mhm. Okay, good. And based on your findings, what is your differential diagnosis or your diagnosis? Good. So this is splenic abscess. So we see there is a large, low attenuating lesion in the spleen which has slightly thick homogeneous wall and there is post-contrast enhancement. So this is splenic abscess. So on ultrasound, we all know that the abscesses appear hyperchoic and they may contain internal septations, internal debris. On CT, they are hypodense with peripheral enhancing rim. So this is important to differentiate it from the splenic cyst. Splenic cysts usually have thin enhancing wall when they are not infected, and abscesses as well as cysts which are infected, they show peripheral uh, thick enhancing rim. And moreover, sometimes in immunocompromised patients, we also see splenic candidiasis, and they present with multiple tiny nodular round lesions. These are basically tiny abscesses, which are more than 5 or 10. And there is also one another entity which can be present in the spleen, that is hydrated cyst. And water lily sign or collapsed membranes are pathognomic of hydrated disease. Okay, so this rounds us, this um, encompasses all our infective diseases, abscesses, candidiasis, hydrated cyst. Now let us move to the next slide. Okay. So, Dr. Atia, please explain this slide. Excuse me. Mhm. Good. So this is arterial phase, this is venous phase. Okay, 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 good. Very. So this is splenic hemangioma. We typically see low attenuating to iso-attenuating lesion on non-contrast CT. Then on early phase, there is peripheral enhancement or puddling. Then there is gradual centripetal fill-in of contrast on subsequent images. And on PET scan, it can show activity, metabolic activity, because there is puddling of contrast or blood within it. Okay. So splenic hemangioma is the most common benign splenic tumor. On ultrasound, we just like liver hemangiomas, these can appear echogenic or hyperechoic. On CT, non-contrast CT shows them to be hypoattenuating or isoattenuating, and on contrast enhanced, we all know that they gradually enhance towards the center. On MRI, they appear T1 hyperintense and markedly T2 hyperintense. Okay. Okay. Dr. Noor. Good. Good. Yes. Okay. Okay, this could be a differential, but in this slide, I wanted to show you a vascular tumor of spleen, which is called littoral cell angioma. This is a rare vascular tumor which arises from the splenic sinuses, lining of the splenic sinuses. These usually present as multiple lesions, hyperattenuating during the portal phase and isoattenuating on late phase. So they enhance, but they enhance very late. On MRI, they are hyperintense on T1, hyperintense on T2. On contrast images, they display delayed enhancement. So let's go back. This is littoral cell angioma. This is a rare benign vascular tumor of spleen. It usually presents as multiple lesions within the spleen, and they enhance very late. This can be in your differential, but common things first. Yes, lymphoproliferative disease should come in on top of your differential list, because spleen is enlarged, and whenever you see these hypoattenuating lesions, you always need to see other areas for lymph nodal enlargement and history of the patient. So to show you this image and this slide is that this should be in your mind at least. Okay. Delayed enhancement means that we usually do phases, arterial phase, venous phase, delayed venous phase, and they gradually pick up contrast. Okay, so on arterial phase, they would appear as hypotenuating. And if you would have done the portal venous and delayed phases, you have seen that gradually there would be contrast enhancement. They would gradually become isotenuating or similar to the enhancement of the splenic parenchyma. Okay, so it would be uh, uh, not similar to hemangiomas, but a kind of enhancement like that we can see. Okay, so okay, so this is a young boy, 14 years old, and he has ill, vague pain, upper abdominal, left side. So, what do you think about this slide? नेक्स्ट सीनियर कौन है नहीं है चल आप बताएं mm-hmm. Okay, okay, okay. What do you think what it is? Is it a benign lesion or a malignant lesion? Okay, so it is benign. Okay, why? Because it has smooth, it is well defined, it has smooth thin walls. The only thing is that we see internal septations over here. Okay, so this is splenic lymphangioma. Okay, patient is young, and there are typical findings of internal septations, as if you see multiple or cluster of cysts, splenic cysts. The appearance is just like a cluster or a bunch of splenic cysts. You can put it put a hydrated cyst in differential, but these doesn't seem like daughter cyst, typical daughter cyst. Daughter cysts give usually spoke wheel type of pattern and or peripheral um, cyst, located cyst. This is just random septate going here and there. There is no enhancement. There is peripheral wall is smooth and there is no um, clinical symptoms to suggest otherwise. Okay, but still, hydrated cyst, yes, can come in differential. Okay, so let's read some words about splenic lymphangioma. They most commonly affect children. On ultrasound, they are cystic lesions, benign cystic lesions. On CT, these are well-defined, hypertenuating with few enhancing septa, rare peripheral calcification. So calcification is very rare. On MRI, these are multiloculated cystic lesion with thin septa, T1 hypo, T2 hyperintense. Okay. Next one. जी आप बताएं. Okay. Mm-hmm. 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 Okay. Okay. What does these features favor? Is it a benign or malignant lesion? Okay. Good. So this is splenic hematoma. So hematoma is basically defined as a benign lesion where the uh, cluster of normal tissues but arranged randomly. Okay. So on ultrasound, splenic hematomas are well circumscribed, homogeneous, solid lesions, predominantly hypoechoic. On CT, they are isoattenuating to hypoattenuating. MRI T1 hypointense heterogeneous on T2 weighted sequences. Post contrast, they show internal enhancement in most of the cases, and they usually give spleen within spleen appearance. So this is very important. This is a typical sign of spleen within a spleen appearance. So this is just like a spleen, a splenic tissue within the spleen itself. So it is isoattenuating to low attenuating on this CT, contrast enhanced CT images, T1 isointense, T2, T1 post contrast, they show internal enhancement, and this enhancement becomes more conspicuous as on later phases, and eventually on very delayed phase, they become iso to the splenic parenchyma itself. Okay, so this is splenic hematoma. This is typically described as spleen in a spleen appearance, a spleen within a spleen appearance. Okay. जी दानियान. Mhm, mhm, mhm. Good, good. What is what is the density of these hypotenuating areas? Water density is that of the gallbladder. Is it similar to gallbladder or lower than gallbladder? Hypo, hypo than gallbladder. Okay. Yes, fat. Good. Okay. So, so what is the benign lesion which contains fat and calcifications? Mhm. Similar to lesions commonly found in kidneys, angiomyolipoma. So they are splenic angiomyolipomas are usually associated with renal angiomyolipomas or in patients with tuberculous sclerosis, tuberous sclerosis. On CT, angiomyolipomas show fat content. This is very important. Can display areas of marked enhancement because this is angiomyolipoma. These show contents of fat, muscle, or soft tissues, as well as vascular components. So they contain vascular components, show therefore they can show patchy post-contrast enhancement. Splenic angiomyolipomas may rupture resulting in hematoma. Okay, so now coming to more rare sort of tumors. So one is the inflammatory pseudotumor. Um, it usually appears as well-defined hypertenuating mass. Calcifications can occur. On MRI, show moderate hypersignal with peripheral hyperintensity on T2 weighted images. Diagnosis on imaging is challenging. Okay, so this should come very low in your differential. As you can see that there is calcification, there is well-defined lesion, there is very minimal post-contrast enhancement peripherally. So this is splenic pseudotumor, which is an inflammatory mass. Then this is another rare tumor, which is sclerosing angiomatous nodular transformation of the spleen. It is a rare benign vascular splenic tumor. On contrast, enhanced CT and MR images, these show peripheral enhancement with progressive central filling, displaying spoke wheel pattern. So as you can see over here that this is sort of spoke wheel appearance, this is progressive central contrast enhancement, but this is not peripheral bundling. The contrast enhancement is that of the septa, which travel from periphery towards the center. So this is because of this fibrous scar which is present within this center of this lesion. So you can see on delayed image it is more prominent, this central scar, and this is spoke wheel appearance. So this is sclerosing angiomatous nodular transformation of spleen. Then this is image of splenic sarcoidosis. We see multiple tiny nodular hypodense foci, and in a typical clinical setting of this is splenic sarcoidosis. There could be overall enlargement of the spleen, as well as there can be multiple iso to low attenuating foci within this spleen. And then this is extramedullary hematopoiesis. We know that in extramedullary hematopoiesis, we can see large paravertebral mass-like lesions, which is basically a hematopoietic tissue. And this can also appear in spleen as well. This should be in a typical clinical setting of hematopoiesis. You must see other areas of extramedullary hematopoiesis like paravertebral regions, and in that typical setting, this can you can call it as extramedullary hematopoiesis. But in normal routine, just an isolated splenic lesion, extramedullary hematopoiesis should not come into your differential. So let's proceed to the malignant focal splenic lesion. These are usually relatively less common. Okay, so Dr. Zara, kindly describe this image. What are your thoughts about the lesion within the spleen? What about its enhancement characteristics? Mhm. Okay. Hmm. What is, okay, so anything in your differentials? So this is splenic angiosarcoma. And this is the most common primary non-hematopoietic tumor. What is the most common hematopoietic tumor of spleen? Lymphoma. This is the most common primary non-hematopoietic tumor. On ultrasound, it can present as multiple complex heterogeneous masses with increased vascularity. Because it is angiosarcoma, obviously it would show increased vascularity, and on CT image, it would show areas of hemorrhage, high density. On MRI, this would again show heterogeneous signals on T1 and T2 vector sequences, again because of its hemorrhagic or hemosiderin contents. Okay, so there is patchy post-contrast enhancement. So this is a picture of splenic angiosarcoma. Okay, okay. G, Dr. Sadaf. Okay. Okay. What are your differentials? Okay, good. So lymphoma is the most common splenic malignancy, splenic enlargement. It can present as a homogeneous splenic enlargement, or it can present as focal splenic lesions. These are usually hypovascular on contrast enhanced CT, isointense on T1 and T2 weighted images. These are the most common lesions we all have seen multiple times, and this should be on top of your differential whenever you see solid multiple lesions within the spleen and especially associated with other areas of lymph nodal enlargement. So let's proceed to splenic metastasis. Uh, the most common metastatic lesions within the spleen are from melanoma, from breast, and also from the ovarian cancer. So the appearance of splenic metastatic lesions should be similar to that of primary lesion. Okay, so these are the metastatic lesions from the ovarian malignancy. So these are cystic, as you would expect from the ovarian lesions. These are multiple cystic come solid lesions which show some nodular post-contrast enhancement, and in the typical clinical settings of known malignancy, you can label them as metastatic lesions. Okay, so we will end here. We have uh, gone through almost all of the uh, rare and common splenic lesions. Um, Common things are first. So whenever you uh, uh, give differentials, gives give common things first. For example, if spleen is enlarged and there are multiple solid hypertenuating lesions, your differential should be lymphoma first. Then metastasis and other things should come later down the list. However, in typical clinical settings, for example, if a patient is young female and she has known sarcoidosis, then if there are multiple tiny lesions, then you can label it splenic sarcoidosis. Okay, so that is it. So we have some time left. So is there any question? I would No question. Chale, good. Thank you.